really with the intent to help create ripples of change toward moving the needle on the mission of Cure CMD. And that mission is to advance research for treatments and a cure for congenital muscular dystrophies. There's a lot of mama or dada bears in our community, and so sometimes we all need help trying to figure out when to let that instinct out and when to just let it lie. And so sometimes that's what we talk about on the podcast.
My kiddo just can't hold his mouth open that long. And so they're really good about, okay, do we need to sit up? Do we need to give you a break? And they rotate him through kind of little phases and everything, but he always gets a little extra time just because he does need to be able to relax his jaw or it locks up.
Get ready for your unofficial dental hygiene podcast. These are the tales of two hygienists, one East Coast RDH and one West Coast hygienist. Listen as they tackle the profession of dental hygiene with humor and enthusiasm. Now, please join Michelle Strange and Andrew Johnston as they tell you a tale of two hygienists.
Welcome back, everyone, to another episode of A Tale of Two Hygienists, the podcast.
And don't confuse it with anything else.
This is episode number 190.
Ooh, 10 more for Andrew before I kick him off this podcast.
We'll see about that. And my name is Andrew.
And this is Michelle.
Well, hello, everybody.
Your future only host.
Look, I know you're getting a little excited. We are actually still in Brisbane recording this one at this point because we are going to be traveling for the next several weeks, and so we want to kind of get ahead of it. And it has been kind of embarrassing how much she has been trying to find a new host in this international event. And I'm just, it was funny the first 30 times.
Listen, you are the one that put a number on this. You said 200 episodes. I'm just protecting myself at this
Look,
point.
I can't quit this podcast, though. That's the thing.
Well,
I need it too much in my life.
Yes, exactly. I agree. And what the heck? I cannot believe we are almost at 200. Like when you threw that number out, it was such an arbitrary number.
You're like, that's future Andrew.
Yeah, okay, 200. If this makes it to 20 episodes, that would be a miracle. And here we are, 190, and well over 200 with all of the tip episodes and bonus episodes and things like that.
So you want me to be done? That's what you're saying.
I actually, this is your last one. I didn't want to tell you that, but last intro for Andrew.
Cut off. No, that's not going to happen. I'll stick around for at least 10 more. We'll see.
Okay.
I think we want to start off this episode with some listener feedback real quick.
Yeah, and we love this. I think if you have come up to us and told us anything about like how much you love the podcast, what you've learned from it, it is truly fuel to our fire. Like we are not lucrative in this podcast world.
What's the opposite of lucrative? Negative monies.
This is a labor of love. It's been for a long time. And our fuel is your love for it. You're learning the lives that you're changing from the information that you're hearing. That's what keeps us going 100%. So I have one that I got. Gosh, I hope I say this right. Maui, M-A-W-I.
Could go either way. And I just love her already, though, because it's a beautiful name.
Beautiful name, beautiful message. And she said, Michelle, I just want you to know that I absolutely love your podcast. I listen to it when I'm driving and doing chores. Like, I love that she's still got chores. We all got them. I feel like I'm always up to date because of it. My favorite speaker is Tom Viola, who we were with this weekend, which was great. And I've since followed him. Please keep up the awesome work. Many people appreciate what you do. I just wanted to share that my fiance and I just recently did a big move. We drove across the country from California to Virginia. And every time it was my turn to drive, I'd play your podcast to keep me awake, which is hilarious.
Yeah.
And not get bored because normally people do this to go to sleep.
That's the opposite for me, yeah. But whatever.
He isn't in healthcare or in the healthcare field whatsoever. So he didn't get the scientific stuff, but I love it when he comments about how interesting some topics were to him and how much he's learning about oral health and its connection to the body. I feel like he has a newfound respect for what I do as an RDH.
It's nice.
Heartstrings. Love that. So thank you so much for taking that time to write that to us. We really do. Like I said, it keeps us going. It does. Yeah.
And that's not the first time that we've heard that kind of message, right? Like so-and-so is not in the healthcare profession whatsoever, but they've learned something. Even our producers have made comments.
Oh,
about
they
that, too.
have. Yes.
They're like, it's an interesting podcast.
One of them went to the dentist after listening to I think it was the Cariology series. So I thought that was fantastic.
So it's beautiful what you guys are doing out there, not only listening it for yourself, but also sharing it with those that you love who are impacted by the messages, whether they understand them fully or not, which I think that's part of, the continuum of lifelong learning. Like even we hear the podcast the first time, like, that's good information. Then we hear it again as we're editing or whatever. Like, I missed that when we were talking to them.
Because we were in the moment.
Yeah. So it's been really good. So thank you for that. We encourage lots more feedback. You know what I forgot to say on the last episode, though, is a thank you and a shout out to Joanne Grenlian.
Yes.
She is just a masterful person. She is so incredibly smart. Speaking of Tom Viola, right? So Tom's been on the podcast before. Joanne's been on the podcast before. I was lucky enough to attend their lecture on cancer. And
cancer patient.
They did such a good job of like playing off each other and supporting each other and turning the time back over to each other. It's almost like they've done that multiple times before, which I don't know if they've only done. I think they've done it one other time before, and they are just, both of them, just professionals at the highest level. So if you see that they are in your area, make sure you go see them. But if you want them to come to your area, please reach out to them and get them to come over, because you will not be disappointed by their discussions. And Joanne's going back to teaching on Monday. So I feel really...
And your friends from Washington.
And my friends from Washington. Sarah Jackson and Lori Spear, who teach over in Spokane, I believe. Gosh, they're just wonderful human beings. It was nice to be able to spend the dinner time with them, getting to know them a little bit more. I think one of the funny things is about the podcast, no one locally knows who I am still.
Oh, yeah. No one gives a crap about me.
But internationally, people know who we are. And I think it's really funny.
Nobody in your own backyard.
You know what? Even at my own office, within my own company, no one knows what I'm doing, or like I'm flying so far under the radar, which is, it's a bittersweet thing.
Yeah.
So when we are able to meet someone like Lori and also like Sarah, it's really nice to be able to connect and like have that, hey, we're from Washington kind of partnership. So thank you again for making time for us.
And we hope the jet lag is not so
good.
bad.
And they're going
back teaching on Monday.
Gosh, they're incredible. So good luck with all that. And good luck for your school year this year.
Yeah. So to kind of circle back to that non-medical people benefiting from the podcast, we have some non-medical people on the podcast today.
Yeah, this is very interesting. So this is very similar to the podcast that you guys heard on diabetes with Stacy Sims. These two are podcasters. They have a podcast called Two Rare Mama Bears, and they are mothers who have children that are affected with congenital muscular dystrophy. And so their podcast is really focusing on that and other kind of rare disease situations. The biggest thing that I actually got from them and their show was honestly when we turned the recorders off. They are wonderful human beings. They are really out there to kind of spread a cheerful, good message of hope and support and love. And they're doing a lot of great things. So we learned a lot what we can do as clinicians to help our patients. And they shared a lot of their insight and expertise. So we hope you guys enjoy this interview. Hey, Michelle.
Yeah.
It's time for the interview.
Oh, but I had something else to say.
We need to let the experts talk now.
Fine.
So today, everyone, we have an amazing podcast for you today. We're going to be talking about the oral manifestations and other considerations of congenital muscular dystrophy, which is, for me, it's a mouthful, but we have two really amazing experts on here who live this life firsthand. We have Maddie and Megan that we would like to introduce you to our show. Thank you for being here, you two.
Thank you for having us.
Hello, and thank you.
You know, I was listening to you guys' podcast a little bit before. You guys have an amazing podcast as well. Can you guys first, like, maybe speak a little bit about the podcast and kind of address that first, and then we'll jump into what we have for you guys today?
Megan, do you want to share our story? It's your brainchild, so.
Sure. Maddie and I first met each other in 2017 at a conference for Cure CMD, congenital muscular dystrophy. It was in DC, and there was a little bit of sightseeing that was happening after the conference was done. And it was she and her husband, and then my family of 4. And during that sightseeing, I think Maddie and I could both tell that we had a friendship that was starting to click. And so after we each got home, we kept trying to find a way to get back together in each other's physical presence, because we do live in different parts of the country. And so there was this opportunity to do some advocacy work in Washington, D.C. for congenital muscular dystrophy. So she and I both went and did Rare Disease Week on Capitol Hill in February of 2018, where we spoke to our federal legislators. I'm from Iowa, so I spoke to the Iowans, and she's from Washington State. So she spoke to the Washingtonians. Is that right?
That's good.
And we had what we call the travel day of hell, trying to get home with a nor'easter coming through. There might have been, 36 hours lack of sleep on Maddie's part, a little bit of deliriousness, both of us wanting to do more, but not quite sure what. In the travel day of hell, being stuck in airports, we were both listening to a lot of podcasts. And I capitalized on Maddie's lack of sleep and said, hey, let's do a podcast. And she turned around and looked at me like I was half crazy. But she then...
We were on the escalators in Georgia, and she's just like, hey.
Yeah, because she's naturally an introvert. And she goes, I can't do a podcast. I can't talk to people. And I said, you just talk to your legislators. You can do this. So she said, okay. And so then we got home. That was the end of February. And so by May 1, we were launching the podcast and we were rolling. So that's how it came together, really with the intent to help create ripples of change toward moving the needle on the mission of Cure CMD. And that mission is to advance research for treatments and a cure for congenital muscular dystrophies. We could tell that she and I liked to connect with other CMDers and that we could talk and continue to connect other families. And so that's really what we wanted to do, was to be connectors within the larger group. And so we just do that by carrying on conversations.
And about how many podcasts do you guys put out a month?
About 2 a month, about every other week.
How do you, just podcaster to podcaster, I know we're going to take a quick little turn here, but how do you come up with the content for what you guys are putting out? And it's Two Rare Mama Bears podcasts. Is that correct?
Mm-hmm. Mm-hmm. Before we got started, we brainstormed a list of 30-ish ideas. We've deviated off that quite a bit. We probably used about half of them. Many of them were individuals in our CMD community that we knew of that were doing something great.
Megan and I are both moms to 2 kiddos with congenital muscular dystrophy. So when we were making that list, we were talking about what were major things that we didn't understand when we were first in this diagnostic journey, when everything started, what impacted our families, where were we looking for resources, who helped us in those situations. And then we kind of went from there on how we could share that information. So maybe somebody else isn't wandering around lost for months trying to find something, that we could at least be someone that could point them in a direction or have resources that they could use.
There's 5 subtypes of congenital muscular dystrophy. And so we knew we wanted to hit each of those. And in doing each of those, there's been people doing something really fabulous in each of those. And so those have been great stories to tell. There's a rock star team at the National Institutes of Health. And so we interviewed one of the physicians there, and that's probably been our most highest listened to episode. And that showed us that that's what our community likes, is hearing some of that research and maybe a lay term of the technical stuff. And so we saw that and then tried to do some follow up to that with 3 or 4 more episodes similar.
If we started at the beginning with kind of each of your guys' individual, so Maddie, your son has CMD, yeah?
Correct.
I like, first of all, is that even the right way to say that question? Like, I feel like there's nuances with how you say the things. How do I even mention that?
I would, he had other people say, does he have muscular dystrophy? He has CMD. His specific subtype, along with Megan's daughter, is SEPN1. So, yeah.
Can I also just, because a lot of our listeners are pre-dental hygiene school, new grads, and then even veterans that have been in it for 30, 40 years. And can we just define muscular dystrophy and what congenital muscular dystrophy actually is?
Congenital muscular dystrophy is a group of diseases causing muscle weakness at birth or shortly after. And that shortly after is before 2 years of life. Under this umbrella, several defined genetic mutations that cause a breakdown faster than they can repair or grow. A dystrophy is different than a myopathy. A dystrophy affects the muscles, and myopathies affect neuronal breakdowns. A person with CMD may have various neurological or physical impairments. Some may never gain the ability to walk, while others lose the ability as they grow older. The difference between those is based on which subtype they've got. We can talk a little bit more about subtypes as we dig deeper. It varies broadly under the CMD umbrella on abilities.
So do we want to tackle like the roles within the Cure CMD?
So Maddie and I are both the podcast co-hosts of Two Rare Mama Bears. We also are team leads for the CMD advocacy team, which this last year was 13 individuals. The year before that was 3. So Maddie and I did a heck of a lot of work to grow that. Next year, hard to tell how many, could be 20. And then I'll be going on the board in July.
So everything that we do within Cure CMD is volunteer. We just kind of saw a need within the community, and Megan knew that we could do it. And so we are here. So this is, like I said, before we got on, my kiddos are out with grandma and grandpa, and your kiddos are out today too, aren't they?
They're upstairs. So we just kind of fit everything in our daily lives and make it happen. So that's part of what we do in the podcast, is to deep dive into issues around caregiving for individuals with congenital muscular dystrophy, special needs, or rare disease. And in doing that, we've kind of both created a tagline or a hashtag for ourselves. Some of that even happened when we were on Capitol Hill. We found ourselves both hashtagging photos with these bylines, if you will. I kept saying, I will leave no stone unturned.
And ours was failure is not an option. My son Matthew is huge into space. And so failure is not an option came from us saying, okay, we have no idea what we're doing, but we have to make it work. So failure is not an option.
And I was saying I was going to leave no stone unturned because I'm relentless. And I will not take no for an answer. So when we could tell this podcast was coming together, we just kind of meshed those together, and that's kind of become the central theme for us. The other thing, obviously, the name of the podcast is totally meant to be a play on words, 100%. So we are 2 total mama bears, and be careful when you poke us, because you might want to run for cover. So there's a lot of mama or dada bears in our community. And so sometimes we all need help trying to figure out when to let that instinct out and when to just let it lie. And so sometimes that's what we talk about on the podcast. We have another episode that's been highly listened to called The Hole. And it's about when you're down in the hole and who's there to help pull you out of the hole. And some of that is when you're down in the hole and people push you further into the hole. And really, it's the mama bear ready to come out of the hole. That was Maddie's idea.
I send all of that to sleep deprivation. It's when I'm most creative.
Those good ideas, yeah.
Part of what we wanted, a goal of doing this with you guys, is a little bit of sensitivity eye-openers, if you will, especially maybe for dental hygiene students or new grads. And some of these are straight from experiences that our kiddos have had in the dentist's chair. So something to keep in mind is realizing that individuals or families with medical complexities have literally been put through the ringer and are often seeing many specialists. For example, my daughter sees 7 specialists.
Wow.
And that does not include the dentist or the orthodontist.
What type of specialists are they?
For my daughter,
Mm-hmm.
neuromuscular, orthopedic, dietitian, otolaryngology, hearing aid specialists, PT, speech. There's 7. There's our 7. And now she's seeing a orthodontist that specializes in special needs.
Very cool.
Mm-hmm.
I think that's really important. I mean, especially from our side, seeing the right type of specialist or subspecialty specialist, if that's even a thing, is really important.
Super specialist.
There, thank you. So my daughter, the reason why I'm going to have some more questions for you guys probably a little bit later on once I hear more, but so my daughter also does PT. She has a speech therapist. She does have some muscular skeletal issues, like just a weak muscle tone. She was born with some kind of congenital defects but no one really knows what's wrong with her still. And so as she's seeing these specialists, I'm like, well, I'll have more questions for you in the future. But she does. I mean, she walks with crutches. She has all these things too. And she's almost 8 now. So I feel like there might be some overlap here that I might need some advice on.
Yeah, absolutely. In seeing all these specialists, and Maddie sees quite a few also, and there are some in our community that see even more than that. They're literally put through the ringer. So sometimes when they're in your chair, their patience might be short because they've been through the ringer. They may know their condition and have researched it so well that they'll know it better than their primary care physicians, and they're likely educating their PCP each time they go. That happens to us all the time.
That's got to be kind of frustrating a little bit.
Even the specialists, you go in and you're talking to even your geneticist going, well, this is what the most recent study has shown where we're going. And, oh, you're off visiting your neurologist. And you're going, actually, here is what it's shown to progress like. And so you repeat your story and you repeat your diagnosis or your child's diagnosis and what is going on with that at almost all your appointments over and over again.
So how do we get to that diagnosis in the first place, though? Because I feel like that's kind of even with my daughter, we don't know still. So
Matthew was born. How old is Matthew? Matthew's 5. He's my second. I have 3 kids. And when he was born, he was super tiny, like under 6 pounds, full term, itty bitty baby. And he was a very floppy baby. And everybody just kept saying, oh, every baby's different. And I kept going, but something's really different. Like, I don't just have another kid, but I also, have all these other friends who have babies within days of his age. And something's just so different. But it was kind of a wait and see kind of thing. He lost a lot of weight initially. And then when he was 3 months old, we ended up in the hospital because he had viral onset gastroparesis. So he was throwing up everything. And he had a feeding tube. We were in the hospital for a week. And that's kind of where the ball started rolling. He started seeing therapists at that point. So Matthew's been seeing his OT, a PT. He's on a break from speech right now, but he's been seeing his therapist since he was 4 months old. And he's 5. And so he knows nothing other than weekly appointments with therapists and regular appointments with doctors. Once that started going, we had therapists and doctors going, okay, what is he doing? And the hard part with Matthew and Lily subtype is that they can meet many of their milestones, but then they have huge holes and huge gaps along the way. So Matthew, which is kind of seems very unlikely for their subtype, walked when he was 1, but at 5 years old, he still struggles to crawl. He never crawled as like an infant or a toddler or anything like that. He completely skipped that because the muscle weakness that they have is in their neck mostly. And so being able to hold his head up and move was incredibly challenging. So he would spin on top of his head across the room like a protractor to crawl. And we saw several doctors trying to get his diagnosis, but they kept saying, well, he meets this milestone, this milestone, this milestone. And we're like, yeah, but something else is going on. Something else is going on. Matthew was one of the youngest diagnosed with SEPN1 congenital muscular dystrophy at the age of 2. And we had one of the shortest diagnostic journeys. In Little Spokane, Washington, we ended up with an amazing pediatric neurologist that watched him for a year and said, I read about this thing once somewhere. I have never seen anyone with CMD. I have no colleagues that have any experience with CMDs, but I read this and I think it might be our best shot. They did MRIs and blood tests and tested for a whole bunch of other muscular dystrophies, and everything came back negative. And then she's like, I think, and then insurance said, yeah, that's so rare. We're not going to pay for that genetic test. Sorry. So we had to go to Seattle and get a second opinion from another neurologist who had experience with other SEPN1 kiddos. And he had Matthew pick up a sticker off the floor and he goes, done. He goes, that's what he has. I'll write the letter to insurance. Insurance approved it. And we sent his blood off Christmas Eve of that year. And at the end of January, we had his official diagnosis. And we have like one of the shortest diagnostic journeys. And it took us 2 years because January is when he started his therapies after he was in the hospital in January. And it was within a week of when he had been in the hospital anniversary that we got his muscular dystrophy diagnosis.
Our diagnostic journey is 3 years, which to us was forever. But there's others in our community that waited 15, 20 years to get the right diagnosis because they were misdiagnosed with something else. For us, she was born normal, air quote, and we really didn't have any signs that we knew then. We now know there were signs if we piece things together now. We didn't start to suspect something, and she's our second child. We didn't start to suspect something until about 6 months old. She wasn't able to lift her head up if she was laying down, or if we pulled her up to sitting, her head lagged behind her. It's called a head lag, and she still does that to this day. Her head does not follow her body. She's like a bobblehead. The milestones she missed then: rolling, crawling, scooting, pulling up, walking. So she started crawling at 13 or 14 months, and she started walking at 17, 18 months, somewhere in there. I first started seeking a diagnosis with her at 11. Well, at 9 months, at her 9 month checkup, I said to her pediatrician, she's not rolling. She should be. Look at this thing with her head. And the pediatrician said, there's supposed to be kids on each end of the bell curve to make it a bell curve. She's probably a late boomer. If she's not doing that at the 12-month appointment, then let's go further. Okay. So at 11 months, I'm seeing that she's still not hit any milestone and the head's still doing the same thing. And I wasn't willing to wait at least another month to get to that 12-month appointment, or however long it was going to be thereafter to get to a specialist. So I took her to a specialty care clinic that would assess her, and they lifted her up. And she still does this. If you lift her under her armpits go straight up to her ears. And that person was like, oh my God, she's like a flappy noodle. And she is like a flappy noodle. And she immediately referred us to a neurologist. So then we do the 12-month appointment, and the pediatrician said the same thing. well, there's twins, blah, blah. So anyway, we saw a neurologist, and that person was trying to rule stuff out rather than rule stuff in. And so we spent a lot of time and a heck of a lot of money on genetic testing with that individual. We were with him for about 1.5 or 2 years. We ended up with yet another referral on the other side of the state to a neuromuscular physician. And within 5 minutes of seeing her, she was like, yes, it's a muscular dystrophy. And that was the first time we'd heard that. And when she said that, we were like, oh my God, thank you. Like, we needed the validation that we were not going crazy, because up until that point, we thought we were going crazy because we had people telling us that we were hypervigilant parents. Guess it was muscular dystrophy, and it's one of 5 things, and she listed off 5 things and ended up being the 5th. To get through those 5 things, it still ended up taking her a year, start to finish, over the course of 2 years, 2 calendar years, and 2 deductible cycles. We were $35,000 into medical debt. So we were literally at the point of medical bankruptcy or selling the house to pay it off. And this is part of my spiel that I'll tell the legislators, like, no family should have to get to the point where they face medical bankruptcy or sell the house to pay it off. But we sold the house to pay it off. At that point, when we sold the house, we realized we needed to get her closer to her medical team, because she was seeing then 3 physicians. And so we moved her across the state. So we now live in the town where the neuromuscular physician is at. So if we really want to go nuts and bolts, we call ourselves medical refugees. We moved to an area to get ourselves better medical care. So 3 years for us. But that's short-ish to some of the other families that we know.
For our subtype. Some of the other subtypes are diagnosed sooner.
So is it subtype dependent on how long it takes, or what takes it just jumping through all the hoops? Like, why does it take so long for certain people and not others?
Because doctors have never seen it and don't know what it is. 1, people end up misdiagnosed with something else. Doctors sometimes aren't doing an actual genetic test. They're just diagnosing off clinical symptoms. So if people we know have gone years and years and years with a spinal muscular atrophy, which is actually a neuronal breakdown, not a muscular dystrophy. So they'll go years with a spinal muscular atrophy diagnosis, come to find out it's actually a congenital muscular dystrophy.
So do all of the genetic testings need insurance pre-authorization before they're run? Is that why it's not done routinely, or what else is the reason of not doing it?
None of them are on the newborn screening panel, and they all need insurance pre-auth.
And it depends on your insurance, if they're going to cover it or they're going to require more or what. And then you fight the fight with insurance.
I can imagine.
You guys have my wheels turning in my head now. I'm actually getting a little bit frustrated. I'm like, this is going to be maybe a long fight after all. We haven't known for 7 years what's up with Molly, my little daughter. And it's been very, Michelle and I are texting back and forth. I'm like, yep, Molly has that. Yep, Molly has that. That happens to Molly too. And I'm like, I said, there's plenty of alternatives. I don't want to like just one podcast and I've diagnosed my daughter, but you start to see those signs, and it's kind of frustrating to hear those stories.
I think there's an amazing story of another mom in our community who has 2 boys with CMD, and she was on the hunt. She knew something was different, and she was trying to find so hard a doctor that would be able to help her. And she ended up going to YouTube and finding another mom who had a kid who moved like hers. And from there, she was connected to the correct doctors. Don't have the same diagnosis as this family she found online, but they were able to point her to some of the doctors that they needed to get to their diagnosis.
One thing, Andrew, though, that we can help you with is that there is an amazing network of neuromuscular physicians throughout the country that we now know. We didn't know them then. And so they're all over the country, and we can help to point your family to the right one in your neck of the woods.
Maddie, I mean, and we're not going to do this on the podcast. We'll do this later. But Maddie, we've been to Seattle Children's. I mean, I don't know how many times when we were living in Yakima, I was telling you off air, like, we went back and forth over those mountains so many every week we were there for the first little bit of Molly's life. And then it was every other week. And then it was just once a month. And my poor wife, I mean, she's had to make that journey. She can do it sleeping now because she's done it enough times. And the whale parking lot or whatever, I don't know, I don't know. But yeah, she knows that one really, really well. And so it's just kind of frustrating that this is still not understood. One thing though, if I can kind of move us along, I took my daughter yesterday to the hardware store because, she likes daddy-daughter time. And I had some chores I had to do. And I remember very specifically this one gentleman just kept looking at her as she was doing her, like she was walking with crutches. I mean, she's got some issues. What have you guys learned about like sensitivity training or the need for it in life and in dentistry / medical professions?
So both of our kids use wheelchairs to go distances, but do get up and walk. And so I've had Lily, my 8-year-old, in her chair, and then she hops up and walks off and goes to look at what she wants. And I've had someone go, "Oh my God, she can walk." And I'm like, great, thanks. And so I, poke the bear. So I'll just, try to be nice and try not to let my daughter see me get frustrated. And I'll just be like, "Do you guys have questions? Can I help you understand something? Oh, you didn't know that ambulatory wheelchair users exist? They do. She needs a wheelchair to go distances. She has muscular dystrophy. She gets tired. She fatigues easily. She's got weak legs. So this is to help her get from point A to point B. And then she gets up and goes to walk and to what she wants to look at. And then generally once people's curiosity is fulfilled, they move on and keep going.
I think there tend to be a lot of teachable moments in life at this point. I remember just a couple weeks ago, we live next to my kids' school, so we can walk to school for pickup and stuff when the weather's nice. So Matthew rode over in his chair to pick up his big sister at school. And the kids see Matthew at the preschool there, and he doesn't have his chair day to day, like in the preschool setting, because it's a small little area and he doesn't need it. But we went to pick up Miranda, and somebody came up to Miranda and they're like, "Why does your brother have a wheelchair today?" And she goes, "Oh, because he came to pick me up and he has muscular dystrophy, so his legs get tired. And this way he can play when we get home and not be too tired." And I was like, oh my gosh, my 7-year-old handled that way better than I ever have. But it's just, I think, answering the question. A lot of people watch and look and it's like, he's in his chair. He's probably going to run over your ankle if you stand in front of him for long enough. But he uses it so that he can keep up with everybody else.
I would say in the medical or the dentistry world, a few things that I wish we would hear more often is using people first language, referring to the individual first and then the disability second. I don't hear that as much as I would hope. We often hear my daughter referred to as a patient, which is not totally PC. Affected individual would be more politically correct.
Can you, before we move on, can you give me an example of like, when are they using it wrong and when are they using it right? Like how would I say that as the dental hygienist that is seeing what we call patient? We call everyone a patient.
Yeah.
Is that different maybe from medical versus dental though?
I have a patient with muscular dystrophy.
Okay.
I have an affected individual with muscular dystrophy.
Let me process that. Well, because I'm thinking like even non-affected individuals, we would still call our patients because they are our patients for dental care. Is that different than maybe the medical setting?
Probably yes. For outside of the medical setting, using the term affected individuals applies more for outside of a medical setting, in that they just want to be seen as an individual and not always termed as a medical something, even outside of a medical setting.
And when we're seeing patients, a lot of times, I think you have mentioned on your notes that their home care isn't usually the or lack of home care isn't the creation of the dental issues, but actually because of the muscular dystrophy. Is that correct?
Right. So if there are some dental hygiene issues going on, it potentially may not be because lack of care. It could be because there are other issues going on due to their muscular dystrophy. I'll give you an example. My daughter has dysphagia, has weak tongue thrust, has a high arched palate. All of them result in her needing to basically be on a soft food diet. And she drinks many of her calories in a high calorie shake. So she doesn't chew many hard foods. And so 2 or 3, 4, maybe dental appointments ago, the dental hygienist and the dentist said, we can tell based on her gums, she's not eating a lot of hard foods. You really should make her eat more hard foods. Because of her diagnosis, because of how she eats, because of her swallowing implications, this is the best we can do. We're working on brushing. We're working on it. Well, then the last appointment, the dentist pulls me aside and basically jumps down my throat about my husband, because she asked who helped my daughter brush her teeth in the morning. And I said, it's my husband. He gets kids out the door to go to school. Well, your husband needs better coaching on how to help her brush her teeth better. And she tried to give me 3 or 4 tips and pulls out a sheet on how to better coach brushing of teeth. And I said, stop right there. As I've mentioned before, it's not that. I've watched them brush teeth. I've watched him coach her. He actually does it very well. It's not that. It is actually because she's not eating the hard foods. And then she went back. She thought for a minute and she was like, actually, you're right. I'm sorry. I didn't think. And so then she prescribed a special mouthwash that my daughter uses to get the bacteria out that she otherwise would get out if she was eating these harder foods. So that's an example of it might not be lack of care, but it could be due to that. It could be a root cause back to the diagnosis.
So is there any tools or tricks or tips that work? So if we do have some hygienists hearing this, maybe that they could teach parents, caregivers, or their patients with habits that they could, or certain products that are maybe better for hands or softer on the tissue.
Or anything that you guys have come across that have worked well, like in your hands. Like, what have you guys done that have been the most successful? And then we can try and mimic some of those things as we're giving our care.
As far as things like at home, I don't know anything that we use differently. I know that I really, really appreciate the dental team that we have with Matthew. Anytime he comes in, they always kind of go down a checklist of questions about his BiPAP use, how that is going. They ask about the types of foods that he's able to eat. His team has done a really awesome job of being aware of his condition and knowing outlying factors that could impact his dental health. And so they do. They ask a lot of questions about how's his BiPAP going? How's he been eating overall? How's he been eating the last couple of weeks? Stuff like that. So knowing, like, if it's somebody you see already and with a neuromuscular condition, having that like prepared before they sit in the chair, and then maybe jumping to conclusions or assumptions about how things are done, just remember already knowing, oh, there may be other factors going on here, and maybe we need to look at some other options or ask some more questions. That is a huge factor in the fact that I drive all the way across town to see this dental team versus something that's only 15 minutes away. And I make the hour commute for this team. So
I think that's a good lesson learned there, though, about the partnership, right? Like it's we're just like those other physicians you're mentioning, even the primary care physicians. Like, we don't know of the things, and it really is beneficial to, I think, everyone. But asking the questions, maybe creating a checklist, co-creating a checklist with the parents to make sure that we're doing our job properly. I think the listeners hearing this are going to really have a good takeaway there.
Also, realizing that some and not just congenital muscular dystrophy folks, but some individuals with very complex health needs are just trying to literally stay alive. And so their care may take a tremendous amount of time every day, suctioning, breathing treatments, feeding tubes, bathing. You could go on and on and on about the different types of cares. And so maybe dental care is not as high of a priority for them. As much as this audience may not want to hear that, the dental care might be further down on their priority list because they're literally trying to stay alive.
Because breathing tends to go to the top of the list. I know, at least for us, because respiratory is so impacted when it comes to the list of things that have to be done in a day. If it relates to breathing, it goes to the top of the list.
My thesis was on aspiration and ventilated associated pneumonia and intensive care units. Why getting that bacteria out of the mouth and cleaning it, which is probably why they put you on chlorhexidine, because that's also a very common thing when you see on patients that are intubated, so that they don't create aspiration pneumonia, since it has got the highest morbidity rate in the ICU.
And my daughter too, she was just doing all of her, she went to the pulmonologist to try and figure out the lungs thing. She's had a hard time with her tongue, swallowing, all the musculatures, all, So you guys are all talking right up my
so much going on in there.
Yeah. I mean, and look, she's like, if she is even close to this, she's so far on the high functioning part of that spectrum that it's not too scary or anything like that. But I think that there's a great opportunity here for everyone to kind of learn, because we are learning on our side through the podcast, through all of our guests that we have on, really serious oral systemic connections. And so as hygienists, of course, we're advocating. And I know a lot of our delivery system is probably not the best. And it sounds like, Megan, you've had some pretty tough experiences with hygienists kind of not working
not thinking,
with you.
Not having critical thinking skills with each patient, unfortunately.
Yeah. And that's totally on us. We need to get better about that. But that's why we're having this podcast, We are kind of running out of time, but I don't want to skip over the kind of the different subtypes. Is it okay if we just jump down to talk about that?
There's probably one thing we should mention before we skip down is that when you encounter a wheelchair user, be conscientious that positioning might be difficult with them, if not painful, and that many power chairs have a reclining option, and a power chair is probably that person's place of comfort or security. And so if possible, let them just stay in their power chair and ask them just to recline it as far back as possible. If they are transferring out or have a caregiver helping them transfer out, offer frequent breaks, and just be conscientious that positioning will get difficult with them and might even hurt. So breaks will be key. The bumper pad things that you can offer for underneath the knee, underneath the neck, have plenty of those on hand. Don't go seek them out in the middle of the appointment. Already have them ready to help some of that support, because they won't be able to support some of their positioning on their own.
I think preparation is a huge part of it. Knowing ahead of time that who you have coming in. For example, Matthew and Lily with the major neck weakness. Matthew can't lay back into the dental chair by himself. He has to have somebody support his head, and we have to lay him down, and we're doing all kinds of adjustments, but being aware that also takes extra time. That also has, it's a whole team. You guys have a huge team in the dental offices between scheduling and getting everybody through, and the whole teamwork aspect of it, just making sure everybody in each stage is kind of prepared for that. Another one I think Megan and I talked about when we were kind of preparing was being able to hold their mouth open and allowing for time to give them that break, because I know my kiddo just can't hold his mouth open that long. And so they're really good about, okay, do we need to sit up? Do we need to give you a break? And they rotate him through kind of little phases and everything, but he always gets a little extra time just because he does need to be able to relax his jaw or it locks up.
Does something like a bite block help them? Or does that also just the act of keeping the mouth open and not giving that jaw rest?
I would say that might cause greater anxiety, because that puts them less in control. And these individuals are so used to being not in control of situations that would be one more scenario where they wouldn't be in control.
So definitely something you to ask and inquire about, but not force upon them. Yeah.
Absolutely.
And have some kind of thing that says, oh, I'm done. I can't do this. I can't have that in my mouth any longer. I need a break, some kind of hand signal for them easily to be able to address a change that's needed.
And that's a good thing to put in the notes, Maddie, too. Just like, hey, this is the signal that they use when they're completely done. And then also all of this communication preparation is yet another reason, everyone, that we need to be having the meetings in the morning before the dental team goes out and does their stuff. It's easy to do. We just talk about it. Hey, make sure we have this prepared, make sure this is prepared, and get on top of that.
Because I've definitely experienced, I've treated a handful of medically compromised patients, and they would have the reclining chairs, which were just fantastic. And, I luckily had the huddles. I had the morning meetings. And so by the time I got that one patient out of the chair, my assistants were already helping me adjust a chair over, getting all those things. But I think it's also just good chart notes, having great discussions with the caregiver or parent or whoever is coming to the appointments, and knowing. And most of the time I ask my patients, because again, they did know more than I could ever investigate or research, or not even just know the questions to ask. Like, they were there to prepare me, and they were kind of my teacher in that situation. And we just kept notes, and just having just very good conversations and addressing everything as it comes up and just making notes on it. Do you want to go into the subtypes?
Sure. So there are 5 subtypes. The prevalence of them is due to some barriers in diagnosis. It's a little difficult to calculate the prevalence of these, but at this point, the prevalence is estimated to be 1 in 100,000 births. And it's thought that this prevalence could change, but various barriers in diagnosis previously mentioned are making that a little bit of a moving target at this point. The subtypes are collagen 6, which includes Ulrich and Bethlehem, and then intermediate collagen 6, dystroglycanopathy, which is Walker-Warburg syndrome, Fukuyama, muscle eye brain disease, and then 5 or 6 genetic mutations of limb-girdle muscular dystrophy.
LAMA2, which is also Morosin deficient, Morosin negative, and SEPN1, which is also known as rigid spine muscular dystrophy or multi-mini core disease. And the 5th one is LMNA, and it's a laminopathy or an Emery-Dreifuss muscular dystrophy.
So there are some oral manifestations that are all common among the CMD subtypes. And I don't think we'll go too deep into each of them, but we'll kind of talk what's common and things that you guys may see if you come across a CMD patient.
Usually it's recommended that any oral surgery is done in a hospital setting for best sedation management and access to emergency services. A lot of the subtypes can have complications with sedation. So being in that setting is really important.
Complications up to and including malignant hyperthermia, which is not something you want to have in your dental chair. Most all of the subtypes have respiratory mask equipment, either during the day or at night or both, usage that can result in pressure onto the jaw and or teeth.
And is that like a CPAP mask or BiPAP mask? What does that look like?
BiPAP, trach, could be tracheotomy. Some people choose to have just the nose mask. Some people choose to have the nose and mouth, and some people choose to have the full face.
Or they don't choose to have the full face. That's their only option for a tiny little.
No.
Yeah.
A lot of them also use suction and stuff like that. So the contact that they have with exterior things on their teeth and in their mouths also impacts their oral health. Like we said before, weak muscles at the mouth may result with them sleeping with their mouth open, dry mouth, and it can cause problems or discomfort having to have your mouth open that long in a chair.
Extensive drooling as well.
So a lot of angular cheilitis that we would see which is like the like a yeast infection kind of in the corners of the mouth. Yeah.
Yep. So in some of the subtypes, not all, but some. Weak distal muscles result in difficulty in reaching the back teeth while brushing and or applying adequate pressure to brush. So when you guys were asking, what tips do you have? I was thinking to myself, some people can't even reach to brush their teeth. So I don't know what tips I can give you because they can't even reach the back teeth. So short of putting the toothbrush on a reaching stick, I don't know.
Here's a question, totally random, because I see it going around Facebook. Those toothbrushes that they're advertising for kids that are like the silicone mouth thing and they just vibrate in their mouth. Or
they're like, no boy, no.
Really get anything clean in there?
No,
And for the record, while we're saying it, Quip sucks too.
Yeah,
don't fall for Quip.
Don't fall for that either.
Such a racket.
I'm trying to visualize. So explain to me again the toothbrush not being able to reach the posterior teeth.
So some individuals can't even reach toothbrush all the way to their mouth.
Okay, so it's more of the reach, not the structure of the mouth or like pulling the tissues aside.
Or they don't have the hand strength to be able to hold a toothbrush firm enough to get back and a firm brush on the back teeth also.
And collagen 6 has joint contractures throughout the body, including their jaw. So some individuals with complex joint contractures can't even get their jaw open wide enough for a toothbrush to get all the way back there.
So I'm asking because I work for a toothbrush company and we are creating a bunch of different tools. And also a really great company called Armor Dental has created something called MouthMate that's really fantastic for retraction. But this is also with a more caregiver, not self-retraction in those specific cases, especially if dexterity is a concern. So I'm just trying to visualize it because I'm wondering if there are products or if our amazing listeners who run the gamut of where they practice, maybe they even have some suggestions that they could even send to us that we could share with
crowdsourced everyone
exactly
rather than a few individuals.
So I don't know if this exists, but I could see with some of our community, this is going to be a bad example, but we call them swooshies at our house, that you use in the shower and you put your body wash on.
Oh, like a loofah thing?
A loofah, yeah. Okay, so my daughter can't reach her own back to wash her own back. She can't even reach her own feet because the bobblehead thing, and she gets too far forward, she would fall over. So we call the swooshie on a stick, which it's on a stick about this long, so that she can just go like this and wash her own back, and that she can barely bend and wash her own feet. We're trying to make her more independent in the shower because she's 8. At some point, she's going to want to take a shower on her own. She still can't get there, but we're getting closer. She still can't brush her teeth on her own. She needs help, and part of that is the reaching and the pressure, right? So if there's a toothbrush that could be more than standard, could be like 3 times as long, and maybe be an electric toothbrush.
Fatter. Oh, yeah. Mm-hmm.
Or have a weighted
on the end.
Kind of help.
Or battery operated, so that all the person's got to do is just hold it there. But like 3 times as long, so that if their hand is in their lap, the toothbrush can still reach. Because think about it, that like people.
These are really great suggestions. And granted, I work for these companies, so it's definitely things that we can tell R&D.
People with joint contractures or with hands that have limited mobility, and this is all their hand can do, which is like a closed fist for those that can't obviously see me, that can only hear me right now, like a closed fist, but could hold a toothbrush in that, and a battery operated one.
No, those are good suggestions. And if any of our listeners have ever seen anything or maybe even rigged something up for patients, let us know. We would love to be able to share that information.
Michelle, this next one is probably something you know about, but in our crowd, rinsing the mouth after brushing has a potential for aspiration, which, because of all the respiratory involvement, is a huge risk for our crowd.
So definitely no water picks and oral irrigators in this group. How about the sponges on a stick for just wetting Is that helpful?
I thought about that too. I don't personally know. I know when I worked at the hospital as a nursing assistant and we had to do oral care, those were fantastic at the nursing home and the hospital.
We'd have to ask around, but I would think that would be a good alternative.
Like you're delivering it still in the mouth, but in a smaller quantity.
Spitting it out might be hard. We probably maybe have to use suction to get it out.
How often can you use suction for like larger, like water? Like if you're rinsing or irrigating, can you do that at the same time? Or is the suction that you're using not meant for that kind of quantity of fluid, I guess?
It's meant for secretion.
So smaller amounts. Yeah, that would make sense. Well, we actually have quite a few listeners that work in elder care where people are feeding tubes and they have trachs and are, not aware and awake on a lot of with their oral care. So again, if anybody's got suggestions for delivering the rinses, because chlorhexidine is it also is a buildup of calculus and tartar on the tooth surface. So there's the downside. There's also a product out there, which I am about to take another course on called Cervatec Plus. And that is a chlorhexidine varnish that can just be painted on the tooth and it will stay there for up to 3 months. And so it doesn't require daily rinsing of it. It actually just sits there almost like a fluoride varnish, which are fluoride varnishes in the ability. Do they paint that on your children's teeth
They do it at my house or at our dentist's office.
So Megan, I think this would be the same thing as that brown bottle we were talking about earlier. You just paint it on as 3 months worth of wholesome goodness. So don't have to worry about that.
Make it easier. And if they do have aspiration,
the fewer times you have to go somewhere.
Right. Yeah.
Might taste better. Lily says that tastes
terrible.
Nasty.
Terrible.
Well, no promises on that one. It's still dentistry after all.
Yeah.
True. One of our last points is that weak mouth muscles will often lead, as we've previously mentioned, to soft food diets or tube feedings. And so that means the person's not able to chew or swallow hard foods, and that can contribute to the dental health.
No, that all makes a lot of sense. So I think a takeaway that I'm hearing is like having really good conversations, always taking notes. You're going to have to probably get creative. You can't be making the same recommendations to a patient that you see on a daily basis that can get up and spit and rinse and brush their teeth and have great fine motor skills. Like it's just not the same beast. And so we have to be critical thinkers, which is what this podcast is all about.
And probably most of all, don't make assumptions. It's okay to ask questions.
I think that's great. Mm-hmm.
Ask questions.
We're going to wind down here in a minute. Is there anything that we've missed, though, that you guys wanted to talk about that we have skipped over?
I think we hit our big stuff. And especially, like we've said several times, like asking the question, not assuming, asking the question, being prepared makes a huge difference, whether it's at the dental office or the medical office. That is the biggest recommendation I could give to any care provider that we work with and interact with.
Read the chart before you walk in. I would say that doesn't happen maybe as often as I would like. Is person just walks in like it's any other patient and you're like, go back and look.
I think that's great advice. And if someone wants to find your podcast, learn more, even check out maybe some resources, how can they do that?
We are on most social media platforms, Facebook, Instagram, Twitter, and you can find us at 2 Rare Mama Bears. We also have a wealth of resources on the Cure CMD website. So www.curecmd.org. And you can find us under podcasts on there, but you can also look in the resources. And Cure CMD has done an amazing job at having numerous resources for everyone there.
If you come across a patient in your practice that has CMD and you want research on CMD, and you don't want to go dig for it, there's actually a really easy way to find it specific to CMD. On Cure CMD's website, on the top navigation ribbon, there is a button called Research, and then you can go down and find specific research on the CMD publication library, and it's by subtype. Yeah, there's a couple of retired librarians that literally go out weekly and just search for subtype specific new publications and then drop the URLs in there. And it's great. It's pretty thorough.
Wow.
That's great.
And if you were to have any questions, you could contact anyone at Cure CMD. You could contact us. We could help if something comes up and somebody needs something more specific.
Thank you so much, you both, for being here. Gosh, that's good stuff.
Thank you.
Thanks, everyone.
So I think my takeaway from this was really hearing we hear people shame all the time, and making sure that we as clinicians remember that we aren't always the expert in the room, that they are always the expert in their life. And we have to engage our patients and their family and their caregivers at every aspect of care, because that's how we get compliance, but that's also how we're more successful in their treatment and prevention.
And I don't know if you guys noticed this, but Stacy Sims had the same exact message. Again, an outsider from our profession, at least, coming in and saying, look, we know what we're doing day to day. You guys don't quite understand. And that's a hard pill for hygienists, I think, to swallow.
Absolutely.
So let's just buck up a little bit and really collaborate and listen and hear. And yeah,
a great message. So we hope you guys enjoyed that. And if you know anybody that can benefit from their podcast, please reach out. It's Two Rare Mama Bears. So we're really thankful for their time and coming on the podcast and sharing their message. And
next week is going to be ADA San Francisco.
Find us. I get it on.
This week?
This week?
Next week.
Next week.
It's next week. So.
Yeah. We will be, I arrive on Wednesday, the 4th, I believe, and you come in the next day, and then we're staying until, I think, Sunday. So check us out. And then I will be actually going to Colorado for a study club there, giving a presentation. If you are going to be there, if you're in that Colorado study club and you haven't seen my name on your future speakers thing, come say hi to me. Or join a study club. You should be in a study club. Everyone should be in a study club of some sort.
Study clubs are great.
And if you want to reach out to us and send us any questions or mail or feedback, we would love it. You can find us on Instagram and Facebook and LinkedIn, and also a tale of two hygienists at gmail.com, or Michelle at a tale of two hygienists.com, and Andrew at a tale of two hygienists.com. And then find us on iTunes, rate us, review us. We appreciate that so very much.
Check out all the tests for your CE on CE Zoom. We have a link in the show notes that'll take you over there. Thank you to Sarah and Kat and the people over at CE Zoom for helping us put that together, and also Lacey for doing all the CE content creation and distribution for that. Thank you also to PDT, who is sponsoring the CE for this episode as well, and every episode that qualifies for CE. They're wonderful people. They support us in our profession, so make sure you guys are really supporting those who make this possible.
And hand instruments are the bomb. Do we still say that? Is that a thing?
Yeah. Everyone says the bomb. The bomb.
The bomb.
So keep saying it because that's cool.
That's me. Super trendy. All right. Well, we hope everybody had a great week and you enjoyed this episode, and we will be in your ears next week.
Bye, everyone.
Bye, y'all.